Gerard Parmentier, who is coming to speak to us about how to integrate the indicators into health information systems.
I'm sorry.
Hello, everybody. It's hard to be the last one because these two presentations was excellent and my English is no good, so it will be hard for you. 3 points in conclusion. Where do we come from? The characteristic of current period and the SDP. Where do we come from? From a world where there were no indicators of practice. We only had indicators of to help medical science, diagnosis, and describe clinical situation. There were a few exceptions. One of those was the exception born in pharmacies in the Middle Age. It was already risk management. Second wave of exception came from the US at the beginning of the last century, when new doctors in Harvard don't find any job on the East Coast, and they must go in Iowa. As you know, it's not very funny. Seems to be not very funny. And their wife don't want to take the train. It was a long travel. And they describe a questionnaire to know what is the state of art of the hospital in Iowa where they could go to work. It's the beginning of the first accreditation procedure, and there was good indicators. But it was an exception. Then we have Donabedian, and this distinction between structure, procedure, and outcomes. Everybody knows that now in our hospitals. But we have a big cultural problem everywhere in the world, only in medicine, because we have no obligation of outcome. And it's a big cultural problem. Then the pioneers proposed to work on structure and procedures, no problem. But they were afraid, doctors and physicians were afraid of them, especially when they talk about outcomes. And the IAS was among the first companies to offer outcome indicators. Originally, there was an experience in accreditation based on clinical indicators in Australia. And you've heard this morning it was finished. It was a very pessimistic presentation this morning on what is about in Australia today. And there was the beginning of a French experience because AFCA, the French Society, wants to go on this way of outcome indicators. And then you know that the first clinical indicators promoted by IAAS. But these steps are exceptional, and they are often misunderstood and even suspected. The question is clear. When you drive your car, do you use indicators of structure and process? I don't. So we have to make progress. Then, what are the characteristics of the current period? Dashboards are still quite rare in our hospitals. For reasons of risk and economic regulation, states are focusing more and more on the way hospitals operate. The most striking examples come from France. It's a unique example. At that time, the law now considers that politicians are more legitimate than physicians to assess the quality of care. In consequence, they control our institution in responsibility of quality called HAS, High Institution for Quality. We professionals, doctors and staff, want more and more to compare our practice. We want to do benchmark. And politicians too, it reassures them when they have to take decisions. In consequence, they became fond of indicators, and in every country, politicians ask now for indicators in healthcare. Then, the SDP. Carlo and Roberto have explained the origin and the result of the project. So it's a considerable work. It has been done by all a team, and we have to congratulate this team for this remarkable work. But we have to be encouraged to take ownership of this result for our action. And the context had to be recalled. I tried to do that very quickly. Now we can explore the question, how do we integrate indicators into day-surgery member state health information system? Huge question. First, we have to debate on this question. Is it the role of IAS to ask such question? It's a real question. Personally, I am convinced that the answer is yes. In terms of indicators, initiatives are more numerous but uncoordinated. Even the responsibility of the European Community Health Indicators Monitoring Programme said that. So we have to coordinate our indicators with others. And that not only on our country, but in a European point of view. It's a hard but necessary job for IAS. We must explain again and again that outpatient surgery is a method of care that reflects an organizational capacity. There is no reason, you've seen that on the precedent presentation, there is no reason to create specific indicators of day surgery. Day surgery is surgery. Rather, the key performance indicators and risk management are, for example, the same. Instead, regulation system requires specific indicators for day surgery. We note that in terms of quality, dimension of ambulatory surgery, indicators about safety, waiting list, and patient satisfaction are most commonly followed than those relating to efficiency, productivity, or equity of access. It's one of the points of the program. But that designates also some area of work for us. Another point of the program is a necessary distinction among the indicators according to the end user. For me, it's quite new. It's a point very, very important, and I never found that in any article before. Even the responsible of European, Claude Dargent, said it was one of the main points from our program, and I think it's very, very important, quite new. It's evidence in the industry, it's new in medicine. The report highlights indeed clearly that indicators should not be the same if it is located on national or regional level, or at the health facility, in fact, the ambulatory surgical unit for us. If it's for authorities of a local level or for management of the unit, in the monitoring of health policy or at strategic option for the hospital or the unit, at the level of monitoring or time frame, or if it is a question of publication. Not only the information needs are different, but the communication policies should be adapted. It's very rarely done, and the adverse effect anticipated nearly never done in our hospital. Then, the work is not over. However, given the result of this work, everything starts, in fact. More than ever, it depends on us, IAS. Everyone agrees that the policy guidance, the regulation, and the incentives are important for day surgery. So we should multiply the bilateral meetings, especially between heads of ministries and/or agencies, If possible, participate in a meeting of health ministers in Brussels, organize a working meeting at the European Parliament in Strasbourg, write and distribute a new policy brief about this subject, develop simple tools and practice presented on a very short and accessible form, encourage the creation of comparative database, and so on. Excuse me, dear President, but I think all that is the following question for us after the program. Evidence for policy making. Quite surprising for us, because at the final meeting of the DSP, Claude Dargent, speaking in the name of the European Community, make many slides on evidence for policy making. It was quite new for many of us, and it was completely new for me. I didn't know politicians have evidence policy. And Claude Dargent noted it was very important, and the outpatient surgery indicators participate to the process. So let's have a look. We must never forget that evidence, what works and is useful in politics, are not the only determinants of politician decision, indeed. It's long ago that outpatient surgery have been proved, but the road is still long, and the innovation in the sense of Schumpeter do not develop itself alone because it changes behavior. It would be so simple to do ambulatory surgery without changing behavior. One more reason to have good indicators, in fact. So I took back some, because Claude Dargent could not come here, unfortunately. I took here some of these slides from the final meeting. As you see, he proposed a definition and objective of evidence-based policy. Remember, it was for us, because it was the last meeting of DSP. His conclusion were many, but you can find this conclusion interesting. And as he said, there is still a long way to translate the evidence produced by our program into ready-for-use material for policy decision, and we have to work hard for that. Where to have influence? We can have a guide on this slide: political knowledge, scientific rigorous knowledge, professional managerial knowledge, and client and stakeholders knowledge. What a work. What is evidence for policy making, and where is it coming from? Another way to say it. Then, our priorities for us, IAS. As the founders thought of IAS at the beginning, our priorities are not medical. We all have learned society to look after surgery and anesthesiology or nurses, and we are all good professionals, don't we? So our priorities in the IAS, even in our Congress, should be, must be, where we need to make proposal. That's organization, evaluation, outcome first, funding, etc. And for that, common indicators are essential tools. Thank you very much.